Welcome to AETCM, the emergency medicine channel.
Yes.
27-year-old male with no comorbidities presented to ER with alleged history of fall and outstretched hand, followed which patient complains of pain and swelling in the right elbow. Initial 10-second assessment, airway is patent with no hoarseness of voice, stridor or gargling of secretions, breathing, respiratory rate of 18 with saturation of 100%, bilateral air entry present, circulation wise, heart rate of 84 per minute with a BP of 120/80, S1 S2 heard with no added sounds, disability GCS is 15/15 with a GRBS of 180 and temperature is afebric.
Okay.
So history of presenting complaint, it's a 27-year-old male presented to ER with alleged history of fall on outstretched hand, post which patient is complaining of pain, swelling and inability to move or extend his elbow with deformity on right elbow is also present.
Right.
So since the patient is having severe pain score was 8/10, we given analgesia, that is tramadol 50 mg IV stat along with MSA was given.
Okay.
And in local examination, inspection wise swelling is present over the right elbow with a prominent olecranon process is seen posteriorly with loss of relationship between olecranon and medial and lateral condyle.
Right.
Elbow is also slightly flexed.
Okay.
Palpation, there is tenderness over the line of joint line with no crepitus. Radius and ulnar pulsation were present with a capillary refill time of less than 3 seconds.
Okay.
A sensory and motor function of median nerve, ulnar nerve and radial nerve was done, which is also found to be normal. Then movement wise, there is restriction of movement, that is flexion and extension of elbow was present. Since there's the elbow joint is involved, we did an X-ray which shows an ulnar and radius is displaced posteriorly with no fractures in the radius or ulna or humerus.
All right.
So we
check the pulses as well, right?
Yeah, pulses are
right.
fine.
Okay.
Radius and ulnar pulse both done, which is normal.
Okay,
Pulsations were same.
Okay.
So with the X-ray and the examination, we came to a conclusion that we are dealing with a case of elbow dislocation.
Elbow dislocation. Okay. So, a case of elbow dislocation, we ruled out definitely if it is a case of RTA and if any other complications were involved, we should definitely proceed with the ATLS route. Let's discuss with the pathology in hand right now, elbow dislocation. So, when we deal with elbow dislocation, we should know about the anatomy of the elbow joint. So, could you please expand?
Elbow joint is basically comprises of the distal aspect of humerus and ulna and radius. So, in the distal humerus, there is medial and lateral condyle. In the medial and lateral condyle, there is a medial condyle trochlea is connected to olecranon of ulna, and lateral condyle capitis is connected to joined to radial head, which forms the which forms the elbow joint.
Yes. So the the medial condyle, the articulating surface of the medial condyle is the trochlea, which articulates with the olecranon process of the ulna. Lateral condyle, the articulating surface is the capitulum, which articulates with the
head of radius.
The proximal head of the radius.
Then medially, the trochlea and ulna forms a uniaxial hinge joint, and laterally the capitulum and radial head forms a pivot joint.
Pivot joint and the hinge joint, right? And could you please the lateral epicondyle and the medial epicondyle
does not give any articulating surface, but the medial epicondyle is the origin of all the flexors of the forearm and wrist
and
including
fingers,
the pronator. And lateral epicondyle is the origin of all the extensors of the forearm and wrist and fingers and supinators.
Along with supinators, right.
Then radius and ulna also form proximal and distal radio-ulnar joints, and also radius and ulna are connected to each other by a fibrous membrane.
Yes, fibrous intraosseous membrane.
Intraosseous membrane.
Right.
Then
so this is one of the reason why the elbow joint is one of the very stable joints. Right, it's very rigid and very less prone for dislocations. In fact, it is the third most commonly located dislocated joints. The first one being the
glenohumeral joint,
which is the shoulder dislocations, and then you have the
patellofemoral joint.
knee joint, patellofemoral dislocation. This one is the third. Right? Okay.
Then this elbow joint is associated with neurovascular structures. In the artery wise, there is a brachial artery which divide into ulna and radial radial artery at the elbow joint location. Then elbow joint is also associated with three nerves. That is the laterally there is radial nerve, medially there is ulnar nerve, and there is median nerve.
Right.
This
so when you check about the neurovascular injuries, it's very important. The arteries you check by the pulsation. And also the nerves, three prominent nerves as you said. You check for the sensory component and the motor component as well. Could you please elaborate on the tests?
In the radial nerve, we will the sensory component is the dorsal aspect of the first web space.
First web space between the index finger and the thumb. Right.
Then
that is the autonomous zone. Autonomous zone. What is autonomous zone?
It's like specifically for the specific nerve.
No, yeah, that is only supplied or the the sensation is
purely supplied by that area by that nerve.
That nerve, right.
Rest every areas will have cross
innervations.
Right.
Okay.
So for radial nerve, it's the first web space, and the motor it is rock and paper, like the extensors and extensions of the wrist and finger.
Extension of the wrist and the finger. Right.
So the second one is median nerve. The sensory is the tip of the index finger, and the motor we can check by OK sign.
OK sign.
The ulnar nerve,
which is the flexion of the index and the thumb.
Right. The third is the ulnar nerve. The sensory is the tip of the little finger, and the motor we have to in the force adduct the fingers against the resistance. So basically we can check all the three nerves with rock and paper scissors with an OK sign.
With an OK sign, right. Okay. So when you talk about the radial nerve, right? The radial nerve has its posterior interosseous nerve component as well, which the distribution or the division happens at the level of the elbow or below it, right? So if at all that nerve is involved in elbow joint dislocations or injuries, we suspect if we are to suspect a radial nerve injury, normally we would have a finger drop, but not a wrist drop. All right, but a wrist drop will be seen when a proximal radial nerve injury is there. Always remember that. And when we talk about the median nerve, right, we were talking about median nerve showing the OK sign. This is with the anterior interosseous nerve component, which is we are testing. And when we're talking about the ulnar nerve, it's a scissor movement. Basically, it is the adduction and abduction of the fingers by palmar interosseous, which is causing adduction, and dorsal interosseous, which is causing the abduction. Remember that. Move it. Right.
Okay. Then examination. Then we go for image.
So how do these patients normally present to us? Like, I have a fall on my outstretched hand, right? And then how would I normally come? So the patient would come with a slightly partly flexed, mostly in 45-degree flexion they would come with a gross deformity, and there will be swelling, severe restriction of movement. One of the you should definitely check the range of movements, which would be flexion, extension, pronation, supination, everything. One of the most exclusive sign would be difficulty to extend completely. Okay, in case of elbow dislocation, if at all they are not able to extend completely, always think about a pathology in the joint, right? Let's move on to the X-ray. X-ray. What all would be the normal X-ray findings? What are the normal X-rays that we would take?
For elbow joint, mostly we take an AP and lateral view. In lateral view, most probably the ulna or radius will be displaced posteriorly. Most common dislocation of posterolateral dislocation of elbow is the most common. 90% of dislocation will be posterolateral.
Posterolateral
so
dislocation.
Most commonly we will see is ulna or radius will be dislocated posteriorly.
Posteriorly in the lateral
view.
And in the AP view, it
there
will
be medial or lateral displacement.
Medial, lateral or displacement. Medial or lateral displacement. Right.
And we have to make sure there to look for any associated fractures. So because most commonly this dislocation may be associated with fracture of coronoid process or the radial head. There is a terrible
triad of the elbow.
Where there will be elbow dislocation associated with fracture of the radial head and ulna. Radial head and coronoid.
Coronoid process of the ulna. Right.
So this terrible triad is an orthopedic emergency. This will form a unstable joint of elbow.
One more thing that I would like to add in the lateral X-ray. When we take a lateral X-ray, there are two lines that we are supposed to keep in mind. One is the radiocapitellar line, which is a line through the shaft of the radius, which would bisect the radial head and also the capitulum. Right? If at all the bisection is not proper, if it doesn't bisect properly, that means there is a pathology in the joint. Similarly, there is an anterior humeral line which should go through the anterior border of the humerus, and it should dissect the capitulum at its posterior 2/3. If at all it is anterior 1/3 that is being dissected, in adults that would indicate a distal humerus fracture, while in children it would indicate a supracondylar fracture. Right.
So this. For this patient, we have a diagnosis of elbow dislocation. Then, since there is no injury or external oozing or external trauma, we decided to close reduce the
do a close reduction of the
dislocated elbow. Dislocation. After getting an informed consent and explaining every side effects and adverse effect, we done the elbow dislocation reduction in using procedural sedation.
After ruling out any comorbidities, you took an agent of the choice and you monitored throughout the procedure. Right. Yeah.
So the elbow dislocation we can reduce two ways. First, both are like 2% reduction techniques.
2% reduction. So for for our viewers, let's demonstrate it, right? Alright, so basically there are two techniques that we would use here. Of course, the patient would be in a the supine position, but here due to the difficulties that we have, we would demonstrate it on Dr. Amal. So the first technique would involve Dr. Rima, who's my assistant, who would be giving a counter traction in that direction over the arm, while I would be giving a longitudinal traction on the forearm. So as I give the longitudinal traction, I make sure that I palpate the olecranon and kind of displace it to its normal location, and once that I do it, I kind of flex the forearm, and as I flex it, I make sure that I give a negative pressure here, and as soon as this position is achieved, I am supposed to hear a cluck sound. Yeah, this would indicate that the elbow is being relocated, right? And I would give immobilization. The second method would involve, as the patient is in supine position, the arms would be abducted, and the forearm is over the torso and flexed. And when this is happening, I, being the assistant, would give a traction in this direction, while Dr. Rima, who's giving the counter traction, would have her fingers over the arm giving a counter traction in that direction, while her thumbs are used to manipulate this olecranon process and push it towards the trochlea so that it goes into place, right? You hear a click sound again. Once this is done, we are supposed to immobilize with a splint. So normally for all the upper limbs, we use a 4-inch POP. Around 10 to 12 layers is what we normally use. Here, from the insertion of the deltoid to the head of the metacarpal is, what we generally give the POP application for. And once it's immobilized, before immobilization, definitely you should check the pulses and the neurovascular deficits, reassess them, put the splint them, and then send them for X-rays and confirm that it's in place, right?
So after immobilization, after getting an X-ray, we ask the patient to review in ortho OPD after 1 to 2 days with adequate analgesic. We can discharge the patient.
Dr. Rima, please tell me what all points would suggest that we should give an emergency orthopedic consult.
In case of open fracture or inability to reduce or recurrent reduction, dislocation or
and also irreducible dislocation. We are not able to do it on our own.
Or neurovascular defects.
Neurovascular deficits. We should get our fellow orthopedics on the floor. Right. Anything else to be added? That's it.
there is one more thing we need to add, which is sedatives in case if the patient is not cooperative on emergency basis, which we can use.
The patient is under procedure sedation, so anyway patient will be sedated enough to perform this.
Thank you.